walking since 14 years. Then fever since 2 weeks, vomiting and loose stools 1 episode.
Okay, wait
Now
a minute,
history
wait a
of
minute, wait a minute. So you are talking about somebody who cannot walk 14 years. What are the possibilities that comes to your mind now?
uh, 14 years. Maybe some
Physiologically, what is the problem he is having?
physio-
Physiologically, what's the problem?
uh, maybe due to some limb problems.
Limb paraplegia
Yeah,
is one possibility. So it may be some orthopedic problem.
yes, yes,
Okay,
orthopedic problems like
it's a possibility of a neurological problem. Somebody is not able to walk. Okay,
then fever since 2 weeks and vomiting and loose stools 1 episode.
so what do you think?
This this and the other presentation has got different time spans. The other
Okay,
ones
this
got
the
different
current problem is different. The current problem is basically fever as a problem,
problem. Fever and vomiting and loose stools
and loose stools and vomiting subsequently has started. So what are the possibilities at this juncture you have as far as fever is concerned?
fever.
It may be gastrointestinal infection. It may be gastrointestinal
Yeah,
infection.
infection.
Viral fever lasting for 7 days is unlikely. Usually they subside by 7 days. So it may be some respiratory infection. In between somebody would have given him antibiotics, and it may be antibiotic induced diarrhea also.
Okay,
So possibilities are wide open. Okay.
okay.
So go to the history.
Now history of presenting illness.
Hmm.
Apparently normal individual who whose this history is not clear.
The born of non-consanguineous marriage.
Uh, is born of non-consanguineous marriage with normal
Milestones of development. Am I right?
milestones of development. Okay.
Okay.
Uh, this weakness progress that he was able to climb stairs, uh, but was not able to climb downstairs.
Or vice versa.
His weakness it is given that he was able to climb upstairs, but not able to climb downstairs.
Okay, fine. Okay, then.
Then
If it is
it
going
was
up,
found
if it is difficult to go up, what will you suspect?
difficulty to go up. Proximal muscle weakness.
Proximal muscle weakness can occur. Proximal muscle weakness, what will be possible causes for proximal muscle weakness?
T.P.Antony said uh, hypokalemia.
Proximal muscle weakness can occur because of muscular diseases. Let it be congenital disease, it may be acquired disease, let muscle disease. Proximal muscle weakness of short duration can occur because of somebody who is having acute infective polyneuritis or Guillain-Barré syndrome. And if it's an insidious onset few months duration, it can be CADP. So neuropathic diseases can produce rarely like AADP, and muscle diseases takes over. What happens to pyramidal weakness? Where is the weakness? Pyramidal disease.
Pyramidal disease, short, small muscle weakness.
Pyramidal weakness to start with will come
Is
for flexors of your hip, flexors
ankle.
for your knee, and dorsiflexors of your foot. Coming to the upper limb, abductors of your fingers will be affected early, and your extensors of your elbow will be affected early. So there's a pyramidal distribution. Okay, carry on.
Uh, then he had to stop in mid to get balance while walk.
Okay, okay, so he has some problem with his balance.
Yes,
So balance of a person depends on which organs.
cerebellum.
Cerebellum,
Then then Then
cerebellum.
posterior column sensation.
Posterior column sensation very important. You know what's the position. Your eyes must be okay. Ears must be okay. And you have got your cerebellum. Yes, extrapyramidal also helps to balance yourself.
Okay.
Okay, otherwise you may fall backwards and forwards. Okay, right. Then
Okay. Uh, then
the,
uh, shall I continue with the history?
please, please.
Okay. Uh, he also had to walk with widely based foot
Wide
in
based
narrow
gait.
wide.
His feet is kept at wide. So his stance is wide. He keeps his feet wide apart. Which are scenarios where you keep it like that?
Uh, cerebellum problems. Cerebellum.
Cerebellar problems you could do like that. But in surgery wards also you'll find huge hydrocele patients also. Sometimes got wide based gait. So in medical wards you think of cerebellar disease. Okay, right. Then
Uh, then he was not able to walk through narrow paths.
yes, what are the scenarios where you cannot walk through narrow path?
Uh, this again cerebellar disease is
Cerebellar
given
disease.
because of
That's right.
because of
Okay, that's fine. That's fine. So how do you differentiate
then
between posterior column producing problem and uh, cerebellum producing problem?
Romberg sign.
No, history wise.
History wise, um,
People who are having posterior column sensation, which are the activities they may find it difficult to do? They may find it difficult to
was
take bath because while taking bath, whenever they close their eyes, their balance is gone and they fall down.
okay.
Similarly, whenever they wash their face in in front of a wash basin, they may fall into the wash basin. Okay, so
Okay.
anything that with the eyes closed, they cannot.
Okay, sir.
And during night, when you walk around, even if it is dark, you are able to walk because of your posterior column. And these people will be totally stuck; they cannot move. So more difficulty coming in darkness at
With eyes
night and the eyes closed. That
closed.
history will point towards posterior column. That history is not there, no?
No, no.
Okay, right. Then
But there was no increased difficulty to walk during night.
okay, okay, that's right. So here posterior column is not there. So whenever you get a history of ataxia, immediately you must differentiate: is it a posterior column problem or is it a cerebellar problem?
Cerebellar.
Right.
He never had any weakness of his upper limb. That he had no difficulty in raising hand above head, in climbing chair, and in gripping objects. There was no history of numbness or paresthesia. No history of no history of ba- no history of back pains and
No history
diabetes.
of numbness or paresthesia. So which part of the nervous system you are checking by that?
Numbness and paresthesia, peripheral nerve, peripheral
Basically you are looking for sensory component of the nervous system.
sensory components of the peripheral nerve.
Sensory component may be in the nerve, maybe in the root, maybe in the tract, maybe in thalamus, anywhere. You are looking for sensory problem. So basically the patient got motor problem, balancing problem, no sensory problem. Okay,
No
then
sensory problems.
then
Uh, then no history of backache and develops uh, and started developing stiffness and heaviness of both lower limbs 15
yes,
years back.
stiffness and heaviness. What does it indicate to you?
Uh, Either a new slowly developing motor
So
motor
stiffness is a feature of pyramidal tract disease. So slowly they started developing pyramidal weakness. So when your limb becomes stiff, three important things you already mentioned takes place. Knee cannot be flexed, it remains extended. Hip cannot be flexed,
Okay.
it remains extended. And foot becomes cannot be dorsiflexed, it remains plantar flexed. So obviously when you cannot bend your knee, you will have a stiff gait. So gait stiffness is looked by looking at the knee, but the patient himself told he has to drag and it is stiff as if some heavy weight is kept there. So pyramidal disease is there from the history. Okay.
Okay. Uh, Initially, his complaint started at right leg. That he noted his that he noticed that his temples were slipped off from his legs with without his knowledge.
Without his knowledge or with his knowledge?
His knowledge with his,
With his knowledge. With his knowledge
yep,
means he knows when it is slipping off. That means it is not sensory, it is motor.
it is no motor
So he is not able to grip the footwear, but he is aware it when it is slipping off.
slipping off.
On the other hand, if he says that he is not does not know slipping off, that means there is a sensory component.
Yes,
Okay.
yes.
So that's how from the history you are differentiating between sensory
Sensory and
and
motor.
motor weakness, producing the slipping of footwear. Yes.
There was no weakness or difficulty in wearing chappals initially.
Initially there was no
Uh,
difficulty to push into the sandals. That means when you reach the object, there is no ataxia to start with. He was able to negotiate into the slippers. If it is a gross cerebellar disease, when he approaches near the footwear, foot will go elsewhere. You got the point?
okay.
Yes, okay, right.
Later on, he found difficulty in walking that he had to drag his foot.
Dragging the foot.
Yes,
Yes.
spastic,
Because it's stiffness. Okay, spasticity.
stiffness. This was more in the right foot to start with, and later progressed to left foot also.
Right.
He used to trip and fall and hitting objects uh, and on trivial obstacles since then on and off.
Why?
Uh,
Why?
because he cannot lift up his foot.
Excellent. He cannot lift up the foot. That's why he is tripping. On the other hand, if it is a foot drop, he will be lifting up his knee such a way that he will avoid the objects and they will have what is called as a what type of gait? High stepping gait.
I
They will
stepping
keep
gait.
the
Yes.
okay, not sensory because of foot
Posterior
drop.
column.
Foot drop.
Foot drop.
You said posterior column. No, posterior column means you do not know where your joint is, so you just stamp it on the ground, forcefully stamp it. So that's stamping gait. Here you just foot is like this, so you lift up. Each time you lift
Okay.
up and keep, so you don't trip down. But here he is not able to flex his hip and knee and dorsiflex his foot, so he is trying to fall. Yes.
Yes. At that time, he had no difficulty in climbing the stairs.
Okay.
Uh, then it's history is jumbled up. Uh, later, later, uh, this weakness progress that later this weakness progress that he was not able to climb upstairs and was not able to climb downstairs.
Okay. Carry on.
Uh, sir, the problem was that I jumbled up the history. The pages were jumbled up.
Okay, don't worry.
Uh,
Don't worry. Bladder and bowels
yeah,
not affected. No symptoms pertaining to cranial nerves. No symptoms pertaining to higher mental functions. Okay. Review system is intact. What do you think this patient is having?
this patient is having
How old is he?
44.
44. His duration of his illness is
The difficulty in walking started 14 years.
14 years.
Since
So,
14 years.
so it is an insidiously developing type of paraparesis. So when you look at paraparesis, first you look at the onset. Acute onset means within 24-48 hours you are totally bed bound. Maximum weakness. Trauma, anti-spinal artery occlusion, gunshot wound, fall from a height, transient spinal cord, all these things will come into this category. If it's developing over 72 hours time, 4 5 days, you got demyelination, transverse myelitis, infections, inflammations, demyelination, abscesses coming up. When it goes to more than that, months, weeks, months, years, possibilities are
Uh, demyelination, motor neuron
is a group of
demyelination.
degenerative diseases, congenital hereditary diseases. They gradually become bad. Neoplasias also can gradually, but they don't last for years together. 14 years very unlikely. So this type of problems can continue for a long time. Deficiency diseases can continue unless you correct it. Toxins can produce problems. It can continue, can deteriorate, continues to be exposed to that. Okay, so we are having problem of chronic disease, slowly progressive, debilitating illness, starting at a very young age. So, is there history of any radiation, use of
No, not
drugs?
mentioned.
No such history. No history of trauma. Okay, so common things that produces the problem of insidious onset paraplegia is not there. So, looking at paraplegia, where from these patients come? Where is he from?
Mm,
He is from Kerala
not
anyway.
mentioned.
So there are places in India where you have endemic diseases like fluorosis. So when they come from there, insidious onset, you may think of fluorosis. There are areas where you have latharism. You may think like that. So this is not a person from that locality. So we don't consider it. So first option is acute, subacute or chronic. So it's a acute onset disease. From the available history, he has got problems of his motor system and he has problem of balancing. So we possibly think that the tracts affected are possibly the motor or possibly possibly sensory is
Motor
paired.
and
Sensory spade, motor and possibly cerebellar. And this has started at a young age and it is progressing in nature. But then we would like to get more negative history in this case. Is there history of root pains?
nothing mentioned.
Okay, root pains are absent. So what's a root pain?
Root pain.
Root pains indicates that the roots are affected. It will be characterized by pain coming from the midline along the spinal cord and it goes along an inner root. In the upper limb it may go along the C5, C6, 7, 8, T1 like that. But coming to the thoracic region, it may come around the chest or abdomen, girdle pain. The lower limb it may shoot along the lower limb. So the site where from it comes, the place where it radiates to, and whenever the intraspinal pressure increases, root pain is precipitated. You move the spine, you bend, you sneeze, cough, strain at stools or micturate, then you get problem of a pain, shooting pain that comes along a root. So root pain indicates the root is irritated. So that indicates that possibly this is something affecting the root
Root.
extradural disease. Okay, so that history is
Okay.
not there. If that history is there, you may think some vertebra is fractured, osteoporosis in old people,
Spinal.
trauma in young people. It may be TB, it may be tumor. Okay, so that's how you look at it. What exactly is the irritating problem of this root? So it may be disc, whatever it is. Whenever root disease is there, you think what are the possibilities. So, okay, in a case of acute paraplegia, on the other hand, you take history of previous viral fever, post viral demyelination, vaccinations, post viral. Any rash suggestive of exanthema, you think like that. Okay, past history of syphilis, music, exposure. It may be retrovirus related myelopathy. It may be something like syphilitic problem. So that those such histories are not available here. So we cannot consider them. No history of trauma. Okay, what is by occupation?
Occupation not not mentioned, sir.
He is a manual laborer and he was carrying weight on his head.
No. Okay.
Okay, so such people can have cervical spondylosis early
Seven right.
and can have cervical myelopathy. Alternatively, if you are having some birth defect of your craniovertebral region, minimum amount of trauma like a small weight falling on your neck, sudden bending can create problem. So the occupational profession are important. Minute details we have to get. Okay. Traffic
Okay.
accidents, whiplash injuries, falling from a height, they all may be important, but not in the case of slowly progressive disease. There is no history of fasciculation in this case. That's a very important point for us. So, what is a fasciculation?
Uh, all, mm,
Fasciculations are involuntary twitching movements of a muscle fascicle.
okay.
Fascicle, not muscle, not fiber, it's a fascicle. Fascicle is a group of muscle fibers, and multiple fascicles will constitute the muscle. So, fascicle will be having involuntary twitching movements. Patient will himself say, if you ask for it, and you can see with your naked eye. Fibrillation patient will not say, and they cannot see naked eye, we also cannot see. So, fasciculation may indicate to you commonly what are the causes of fasciculation.
Uh, cranial nerves in uh, re-
Common thing is motor neuron disease.
basically.
Motor neuron is the commonest for you undergraduate students. Motor neuron disease indicates anterior horn cell or the root LMN is irritated. So irritation of anterior horn cell or elsewhere will produce this problem. So motor neuron disease is a disease affecting the anterior horn cell. It's a slow disease, insidious. Such conditions can produce fasciculation. Okay, anything that
Okay.
irritates. It is not specific for motor neuron disease. It shows that LMN is irritated. That's all. That history is also not there. So, from the history, the absence of fasciculation, motor neuron is a rare possibility. Right. So, from the history so far, is upper limb affected?
Upper limb is not
Not
affected. Lower
affected.
limbs are
Lower limbs are affected. Is the speech affected from the history?
no.
No. Okay. So, carry on.
No history of cognitive impairment.
Okay.
Sir, one more. This is there. Since 2 days, his complaints worsening his neurological symptoms that he was not able to stand without support or walk without support.
Okay, any person with a chronic disease, whenever he has intercurrent another illness, it will deteriorate. But today morning I checked him, he is able to walk independently. Okay, so that's a transient. Such worsening do occur. In patients who are having very high fever, when they suddenly deteriorates, we think about multiple sclerosis, Ultoff's phenomenon. Okay, that is not the history here. This is different story. Okay, back to you.
Then one more
Past
management.
history, no similar illness in the past.
Uh,
If somebody gets
there is no.
repeated attacks of paraparesis, we are thinking of multiple sclerosis, heavy malformation bleeding recurrently. Okay, so that's how you go thinking. Recurrent episodes. People with porphyria may have recurrent episodes of weakness. Paraparesis. Okay. Family history.
Family history. There is no significant history in the family.
What exactly you want to know? How many members are there? How many siblings has he got?
He's got three siblings, two siblings.
He's the third one. So
It's given that he's first one.
no, there are three members and he is one among them.
Three members. Three members in the family. He is the eldest, I guess.
Okay, he is the eldest.
Here is the
So no family history. What are the familial diseases which can present like this? Initiated onset weakness of the lower limbs, predominantly lower limbs.
motor neuron disease.
Not commonly. Motor neuron disease in the family rarely it occurs, but not commonly. Hereditary problems in the families.
Okay.
Okay, muscular dystrophy is one. Hereditary spastic paraplegia. Friedreich's ataxias. Hereditary degenerative diseases can run in families. Okay, Charcot, Marie tooth disease, muscular dystrophies, they all run in families. So, what is the type of transmission of hereditary spastic paraplegia?
Autosomal.
Autosomal dominant. So, what is the type of transmission autosomal dominant diseases? It's a vertical transmission. And what are the chances of offspring getting the disease?
Then 25%.
50%. 50%. 50% will be getting. All generations are affected unless it's a mutation. If it's a mutation, siblings may not be affected, parents may not be affected, there may not be any history in the previous generations. The new mutation can create problems. Okay, so we have to keep this possibility also here. Okay, carry on.
On examination,
Personal history, nothing is given, no?
nothing.
You must know that if the history of music is there, you can have syphilis producing tabes dorsalis affecting the spinal cord. You must also remember retrovirus is associated with myelopathy, right? Okay, then drug history.
Drug history is not given.
So drug history. Drugs are well known to produce neuropathy. So some patients say I am bedbound after chemotherapy, mingristin for example, severe neuropathy. Some people say I am bedbound after taking certain medications because of myopathy. Some people get myoneural junction disease following treatment. So they say it's a neuromuscular junction disease. So different types of neurological problems can occur following treatment with different conditions, and you can have weakness of lower limbs. So drug history is important. Is he a vegetarian or a non-vegetarian? Again, that becomes important to us because
Vitamin
B12 can produce problems.
severe
Okay,
pain.
yes, it can produce problems. It can produce problems. So there can be sensory ataxia there can be pyramidal weakness. That's very good. Okay, then
Then other histories, there is treatment history.
what are the activities of daily living he can do?
Activities of daily living? He can mm,
He can almost all do everything. He can look after himself. Okay, go to general examination.
okay. On examination, patient is conscious and oriented.
Before
There
that,
is
whenever you have got a paraplegia patient, quadriplegia patient, what all things we like do at the examination specifically? Some things will be in your mind, no? B12 deficiency, what you look for?
anemia.
You look for anemia. The skin, what you look for?
In,
You will have pigmentation. That's why it's called as
okay.
Addisonian pernicious anemia. Addisonian type of pigmentation of your palmar creases. So hyperpigmentation knuckles, pressure areas, very characteristic of B12 deficiency. So B12 can be easily found out. Yes. Anything else specific look for general examination?
Uh,
People who have taken arsenic because they have gone for the homeopathic treatment, other complementary medicines, they have a classical appearance on the skin. That also has to be specifically looked for, because diagnosis come from that. Meese lines in your nails can be suggestive of which disease?
oh,
Yes.
uh, mm,
Meese line is commonly seen in arsenic poisoning. So there may be clue
yes, yes, yes.
from the examination. Then you look at the person's altogether appearance, and what do you make first appearance may give you some diagnosis. But basically you have to look whether this person is having congenital problem or acquired problem. So deformities occurring from birth are all pointing towards your congenital problem, like your pes cavus. What is pes cavus?
Yes, what a foot, uh,
High arched foot. High arched foot. Okay,
higher foot.
that may point towards conditions like syringomyelia, Friedreich's ataxia. Kyphoscoliosis may again be a marker of a hereditary disease. Okay, if you are finding a very short person, you have to think about some congenital problem. Similarly, if you are finding somebody is having very short neck, maybe some birth defect is going on. If you are having cafe spots, can you describe cafe spots?
Fairly sports is seen in
What color?
brown,
Brown. Okay, good.
brown,
Cafe, coffee color. That may point towards inside there may be
neuro,
couple of neurofibroma. That's okay.
no,
Fine. If you find similarly AV malformation on the skin, vascular malformations, you find lipoma, same thing may be there in the same dermatome inside, same iotome may be affected. So you may get a clue. Neurofibroma all over the body may give clue this person is having some problem. So cafe spots very important. Similarly, you also look for tuberous sclerosis, but they don't usually come with paraplegia. Okay, so couple of important things in the general examination for paraplegia patients. When we said about the fasciculation, is there any other involuntary movement that you may get in the history or general examination?
mm,
There is something called as flexor spasm and mass reflex. What is flexor spasm? Whenever you touch this patient skin anywhere, for example, you just take a bed sheet and cover him, even that sensation can produce sudden flexion of the lower limbs. This is called as flexor
success,
spasms. They indicate that there is a complete transection of the spinal cord. All the tracts are affected. Extrapyramidal is also grossly affected. That's what it means. It is not a good sign. It is saying that the disease is bit extensive, severe, and progressive. They may not do well. Now,
okay.
now, what else can you do? What else you look for? Mass reflex. What is mass reflex? Same thing. Along with that, sweating, and defecation, and micturition is called as mass reflex.
Mass
Okay. Also you may find by just doing general examination, you find this, you'll be able to get a clue. If you are finding clubbing and lymph nodes, of course you know possibility of tuberculosis is there, and malignancy comes top in your mind when there's clubbing. Lymph nodes can be tuberculosis or metastasis. Okay, so keep the options open wide, but 14 years history, malignancy is unlikely. Go to examination now.
now on examination the
General
points
examination
or
is over, and higher functions. Nothing, anything
higher
special.
mental functions. Uh,
Speech.
on gait is wide base gait,
Yes, speech.
and there's truncal ataxia.
Triangle attack is there. How do you elicit triangle ataxia? unsupported,
Yes,
and they will be swaying.
unsupported with his eyes swaying.
So which part of the cerebellum is affected when this triangle ataxia? Midline vermis, possibly. Yes. Okay. Then
Then there is a spastic type of dysarthria.
spastic dysarthria. So what are the causes of
Yes.
spastic dysarthria? What do you get spastic dysarthria?
Mm, here again cerebellar problems.
Cerebellar dysarthria is different from spastic dysarthria. Spastic dysarthria points to pyramidal lesion.
Okay.
So patient is having pyramidal lesion above the level of fifth nerve, 12th nerve. Okay. So it's a grunting type of speech. Okay. Spastic speech. Okay. Then it is
Then
maybe explosive sometimes. Okay, right?
okay.
Cranial
Then
nerves.
cranial nerve one is normal.
All cranial nerves are normal.
No.
Right?
Then
All cranial nerves are normal.
yeah, yes sir.
All the cranial nerves must be
Then
properly examined because there may be loss of vision in one eye, neuraminutes optica. There may be optic neuritis in multiple sclerosis. Okay, there may be 3, 4, 6 nerve involvement in case of tuberculosis. If there's intracranial problem like meningitis associated with it, okay, fifth nerve may be affected, like excited jaw jerk,
Georgia.
if there is a pyramidal lesion above it. If it is the lower cranial involvement, then of course you have to think about something in the upper part of the spinal cord near the junction between the medulla and sorry midbrain and other structures. So lower cranial nerves can also be affected if there is a problem around the foramen magnum. So that's important here. But as far as history is concerned and findings are concerned, given to you is everything is normal.
Normal.
Suppose you get
Nine.
a ARP, ARP, ARP.
Okay.
What is that?
Arjun Robertson pupil.
Describe that pupil.
Uh, Arjun Robertson pupil. It's like uh,
Small, irregular, asymmetrical pupil.
silence.
Small,
Uh,
irregular, asymmetrical pupil
yes.
with the pupil
Did
reflex
not
preserved and accommodation reflex present, pupil reflex absent. So it may suggest to you this basically having possibly having syphilis. Okay. Bilateral seventh nerve palsy with paraparesis may be a feature of Guillain-Barré syndrome. So all the cranial nerves needs to be examined in case of paraplegia. Here all are absent. Motor system other findings. Gait you already mentioned. With the tone, wasting,
tone.
wasting.
Tone increased bilaterally.
No wasting, no.
Uh, no wasting.
No
Quite
wasting.
symmetrical.
The spasticity is present. Spasticity indicates pyramidal disease. Rigidity indicates extrapyramidal disease. So you got spasticity of upper limb, right?
Upper limb.
Yes or no?
Lower limb.
Lower
Lower
limb.
spasticity of
Upper limb spasticity is not there. Not there. Okay?
not mentioned.
Yes. Power.
And power. Power and everything is normal. Everything is 5 out 5 and power.
In a lower limb also.
Lower limb. Yes. Yes sir. Given 5 out 5.
5 by 5. And Beaver sign.
Yes. Beaver sign. Not
What is Beaver sign?
when you stop above at the level of umbilicus. Uh, uh, then it will when the patient is have to what was this?
When there is paraplegia, Beaver sign, the umbilicus will move upwards.
Umbilic raise the head.
Okay, raise the head against pressure and the umbilicus will move upwards, right?
Umbilicus will move upwards.
That is not there. Okay. Lower limb power is normal, right?
Normal.
Is it given like that?
It's given as 5
Okay.
on 5 by
Reflexes, deep tendon jerks.
reflexes superciliar abdominal bilateral plantar extensor.
No, No, come to upper limb.
exaggerated.
Upper limb reflexes.
Upper limb, it's exaggerated. Everything is
Exaggerated.
exaggerated.
Lower limb also exaggerated. Okay. Superficial reflexes.
Superficial reflexes, abdominal reflex is present, but bilateral plantar.
Abdominal reflex is present, cremasteric is present, and plantar is upgoing. What do you think about it?
Again, in pyramidal lesions,
A pyramidal lesion, what will happen to abdominal reflex and cremasteric reflex?
uh, in superficial reflexes, if it is uh, 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 superficial reflexes will be normal.
Superficial reflex will be
Again,
lost in case of acute pyramidal disease. So you don't expect abdominal reflex and cremasteric to present in a pyramidal lesion. If they are present, we have to suspect possibly it is a congenital, hereditary, or degenerative disease. Only this category of diseases will their abdominal reflex and cremasteric reflex is present. So please remember, if you bluff in the examination that all these reflexes are present in the case of pyramidal lesion, definitely it will be checked whether you are right or not. What we commonly expect is they are absent. If it is present, it indicates to degenerative or congenital problems. Very good, very good. Okay. Then
then again bilateral in the plantar.
that indicates
Then
pyramidal lesion, and upper limb reflex are also brisk, exaggerated. That means the lesion is above C5. Okay. So
okay,
so sensory system is normal. Cerebellar signs.
uh, cerebellar signs, coordination, finger nose twist is positive, no involuntary movement. Right, right finger nose twist is positive.
What about the gait of the patient? Any special
Gait
mention? In this patient,
mentioned here.
tandem gait is not possible. It tends to fall to either side, more to the left side. What does it mean to you? Bilateral cerebellar disease. So he's got bilateral cerebellar disease. He has got bilateral upgoing plantar. So he has pyramidal more than the upper limb problems, and he has got spasticity. He has got spasticity.